Yeah, so I'm also going live then. Hello everyone, this is Dr. Vaishnavi, your ENT faculty for the PrepLadder platform, and I'm here today to discuss with you the FMG questions of the last 5 years. Yesterday we have done 2019 and 2020 questions. So today we are going to do 21, 22 and the Jan 23 questions. So if I'm audible and visible to all of you, do let me know in the chat box so that we get a quick confirmation from your end that the relay is going on well and there is no confusion. Yeah, so everyone's going good with the relay? If yes, quickly inform me in the chat box. Yes, so I think Anjali, Dr. Right Hand, Med Psycho, all of you are able to hear me well and we can start the session. Okay, so I think that's good enough and we can start the session. Okay, which of the following is a part of the Trotter's triad seen in nasopharyngeal carcinoma? Now, I have shown you yesterday in 19 and 20 also we had the questions coming from nasopharyngeal carcinoma. We had the questions coming from Trotter's triad even in 22, 23. So please remember that nasopharyngeal carcinoma, juvenile nasopharyngeal angiofibroma are absolutely important topics. You cannot go to the exam hall without studying these topics. So now quickly tell me what is a part of the Trotter's triad that you see in NPC. Option 1, conductive hearing loss, ipsilateral temporoparietal neuralgia and palatal paralysis. SN loss with contralateral temporoparietal neuralgia and palatal paralysis. SNHL, ipsilateral temporoparietal neuralgia and palatal paralysis. Conductive hearing loss, contralateral temporoparietal neuralgia and palatal paralysis. Yes, so let me know what do you think is the right answer. So typically in nasopharyngeal carcinoma, this is known to invade or it is known to erode the base of skull. So since it erodes the base of skull, it can cause cranial nerve palsies. Now, which cranial nerves does it involve? It involves almost all the cranial nerves. But typically when we talk of Trotter's triad, there are two important cranial nerves that we are concerned with. The cranial nerves that we are concerned with here in Trotter's triad is cranial nerve 5. So where they have got temporoparietal neuralgia. So in the area of the distribution of the fifth nerve, there is pain. And along with that, there is palatal paralysis. Now, this is ipsilateral, not contralateral. So there is palatal paralysis, temporoparietal neuralgia, and there will be conductive hearing loss because of serous otitis media. So this unilateral conductive hearing loss with ipsilateral fifth nerve involvement and 10th nerve involvement is called as Trotter's triad, which you see in nasopharyngeal carcinoma. So the correct answer is option 1, conductive hearing loss, temporoparietal neuralgia, and palatal paralysis. So I think this was easy question. The next again is a super easy question asked 1,000 times, 1 lakh times, 1 million times. I'm sure I can tell this, till the infinity this question has occurred again and again, again and again in the examination. I don't even feel like reading the question because I'm sure all of you will answer this in a jiffy. But still I will read. A patient was diagnosed with a ear wax and was subjected to syringing, and she developed a syncopal episode while doing the procedure. When the tip of the syringe touched the external ear, what nerves is responsible for this episode of syncope? So syncopal reaction, when it occurs in external auditory canal, it occurs due to which nerve? I think this is a standard question. All of you know this question. So like quickly answer to me, what should be the answer? Is it auriculotemporal, Arnold's nerve, glossopharyngeal nerve, or Jacobson's nerve? Yes, I'm waiting for your answers in the chat box. Great, everyone's right. So basically, we know that whenever there is a syncopal reaction, there has to be a vagal stimulation, and the vagal branch that supplies the external auditory canal. So the auricular branch of the vagus nerve is called as the Arnold's nerve. So the auricular branch of the vagus nerve is called as the Arnold's nerve. Okay, so Arnold's nerve is auricular branch of the vagus nerve, and syncopal reaction happens due to stimulation of this nerve. Now the question can be cough reflex is occurring due to which nerve? The answer will still remain the same, which is your Arnold's nerve. And if I come to the nerve supply of the external auditory canal, the roof of the external auditory canal and the anterior wall of the external auditory canal, these both are supplied by your auriculotemporal nerve. So both of these are supplied by your auriculotemporal nerve. The floor of the external auditory canal and the posterior wall of the external auditory canal, these are supplied by your vagus nerve, the branch of the vagus nerve which is called as the Arnold's nerve, also called as the Alderman's nerve. This is a pretty simple question. We will not go into more of this because I'm sure everyone knows this. Let's go to the next question very quickly. A worried mother brought her 6-year-old unimmunized child to the ER with complaints of fever, cough, and shortness of breath. On examination, there is a pseudo membrane. They are giving you the direct hint that there is a pseudo membrane over the tonsil, which on trying to remove is bleeding. So it bleeds on peeling. There is also bull neck. So what do you want more? So there is already pseudo membrane. There is already bleeding on pulling the membrane out, and there is also bull neck. What will your diagnosis be? Again, a very easy, pretty simple question, which I know all of you know the answer for. So what's the answer? Is it infectious mononucleosis? Is it tonsillitis? Is it diphtheria? Or is it candidiasis? So I'm sure everyone knows this. I don't have to ask this. Absolutely right. Dhruv, Ravi, Priya, Harjeet, Paras, absolutely right. The correct answer is diphtheria. Okay, so the correct answer is diphtheria. So if I have to differentiate membranous tonsillitis from diphtheria, there are few very important points. Now, membranous tonsillitis occurs because of streptococcus. Diphtheria occurs due to corynebacterium diphtheria. Now, when we talk about membranous tonsillitis, the membrane is pearly white in color, whereas diphtheria is grayish white in color. Now, membranous tonsillitis on peeling, it will not bleed. It does not bleed. Whereas diphtheria on peeling, the underlying surface will bleed. Now, membranous tonsillitis, the membrane is limited to tonsil. Whereas in diphtheria, it will spread to the adjacent tissues like to the oropharynx, larynx, palate, tongue base, etc. Now, membranous tonsillitis, the membrane will come from the tonsillar tissue, hence it is a true membrane, whereas in diphtheria you will get a pseudo membrane. And additionally, you will get bull neck, toxicity. All of these are features of diphtheria. So this is a very quick important revision pointer that you should know to differentiate membranous tonsillitis from diphtheria. Okay, so let's go to the next question. A 6-year-old boy fell from the bed and developed swelling in the nose and difficulty in breathing. Examination revealed smooth, rounded swellings on either side of the septum through both the nares. On palpation, it was soft and fluctuant. What is the next best step in the management of this patient? Systemic antibiotics, incision and drainage, high resolution computerized tomography, submucosal resection. So again, this is a very easy question. There is a history of fall, and after that there is a swelling on either side of the septum. So if I take this as the septum, on either side of the septum there are smooth rounded swellings. Okay, now it is soft and it is fluctuant. Fluctuant means there is a sort of a fluid inside the swelling. So what will you do after a history of fall? If there is a swelling, what will your diagnosis be? The diagnosis will be septal hematoma. Now, a septal abscess also can present to you with the same clinical feature, that there is a smooth rounded swelling on the either side of the septum. But what's the difference? The septal hematoma patient usually will not have fever, will not have headache, will not have lymphadenopathy. But if it is a septal abscess, in the history, in addition to the swelling, they'll give you fever, headache, and lymphadenopathy. So those three features are not there. So we're thinking about septal hematoma. And when we're thinking about septal hematoma, what will our answer be? Absolutely right. The correct answer will be incision and drainage of the hematoma. But the most important point in the treatment is pressure packing. So you are going to pack on either side of the septum. So if you take the septum on either side of the septum, you're going to pack either with ribbon gauze or with Merosil sponges to apply pressure on either side of the septum to prevent reaccumulation. Okay, so I think this is very easy question. Let's go to the next question, which is battle sign. So what is battle sign? Is it mastoid ecchymosis? Is it periorbital hematoma? Is it Bezold's abscess, or is it perichondritis? So what do you understand by the word battle sign? Yes, waiting for all of your answers. What is the meaning of battle sign? So we know that whenever there is a head injury or a RTA, road traffic accident with a head injury, the most common, or usually it is associated with middle cranial fossa fractures. And when there is a middle cranial fossa fracture, you will see bluish discoloration of the mastoid. So that bluish discoloration that you see of the mastoid, this bluish discoloration of the mastoid, this is called as battle sign, which is seen in mastoid ecchymosis. Okay, so mastoid ecchymosis presents to you with a bluish discoloration of the mastoid, typically seen in middle cranial fossa fracture. This sign is called as battle sign. Now, again, there is another condition where you see edema and bluish discoloration of the mastoid, which happens as a complication of CSOM, which is seen in lateral sinus thrombophlebitis. So whenever there is a sigmoid sinus thrombosis or lateral sinus thrombophlebitis, what will happen? There is obstruction to the drainage of the mastoid emissary veins, and as a result there is edema and bluish discoloration of the mastoid, and that sign is called as Griesinger's sign. So if in your exam you just given bluish discoloration, if they have given you a history of trauma, then you should think about battle sign. But if they have given you a history of CSOM and they have told you there is a bluish discoloration of the mastoid, then you have to think about Griesinger's sign. So the sign is more or less the same. It looks more or less like this only. The only difference is history. If there is a history of trauma, a battle sign. If there is a history of CSOM or a complication, then the sign is Griesinger's sign. Okay, so I think that's absolutely easy for all of you. Now, whenever there is a periorbital hematoma, you will see one sign which is called as raccoon eyes, also called as panda eyes. Bezold's abscess is whenever the pus trickles from the mastoid. So if there is a mastoiditis and the pus goes into the sternocleidomastoid muscle, we call that abscess as a Bezold's abscess. And in perichondritis, there is no specific name given to the sign. Okay, let's go to the next question. Which of the following statements is true with respect to Little's area? Kieselbach's plexus is in Little's area. It is situated in the posterior-inferior part of the nasal septum, least common site of epistaxis. Anastomosis of 7 major arteries occur here. So they're asking you which statement is true. Out of the 4 statements given here, which statement is true here? So if we take the blood supply to the septum, we know that the upper half of the septum receives its main blood supply from ICA circulation. ICA gives rise to ophthalmic artery, and ophthalmic artery will divide into anterior ethmoidal artery and posterior ethmoidal artery. Then from below, the lower half of the septum receives its main blood supply from external carotid artery, which will give rise to 2 arteries, facial artery and internal maxillary artery. The facial artery will give rise to a branch which is called as superior labial artery, and internal maxillary artery gives rise to spinopalatine artery and greater palatine artery. So here we have anastomosis of the 4 arteries, anterior ethmoid, superior labial, spinopalatine and greater palatine. They all form an anastomosis at the antero-inferior portion of the septum. This area is called as Little's area, also called as Kieselbach's plexus. So this is your correct answer. Kieselbach's plexus is present in your Little's area. It is not situated in the posterior-inferior part. It is situated in the antero-inferior part of the septum. It is not the least common, but it is the most common site of epistaxis. Here there is anastomosis of 4 major arteries, not 7 major arteries. So the correct answer is number 1, which is antero-inferior portion of the septum. Now, corresponding to the arteries, we have a venous plexus located in the posterior end of the septum. So that venous plexus located in the posterior end of the septum is called as Woodruff's plexus. So Woodruff's plexus is in the posterior end, Little's area is in the anterior end of the septum. So I think that was a pretty easy question. A 14-year-old male presented with recurrent epistaxis. Again, a common question. If you see juvenile, if you see male, if you see epistaxis, one answer should hit your brain without even me telling anything. Yesterday, we discussed some very important points about this also. He has no history of trauma, but also there complaints of nasal obstruction and rhinorrhea. On examination, there is a purple firm mass present in the posterior nasopharynx. What is the most probable diagnosis? Nasopharyngeal carcinoma, rhabdomyosarcoma, pyogenic granuloma, juvenile nasopharyngeal angiofibroma. I think this is also a very easy question. Whenever we talk of juvenile, whenever we talk of males, whenever we talk of bleeding, whenever we talk of obstructive symptoms, there is one particular diagnosis that should hit your mind. The answer should be juvenile nasopharyngeal angiofibroma. Nasopharyngeal carcinoma typically presents in older age group, can present more often in male, but it will not present to you like a firm purple mass presents to you as an ulceroproliferative mass. So this cannot be an answer. Rhabdomyosarcoma and pyogenic granulomas are very rare occurrence disease, especially in a male, and they do not usually present with epistaxis. Okay, let's go to the next question. A 35-year-old woman presents to you with complaints of difficulty in hearing in the right ear. So there is a hearing loss in the right ear, which is slowly progressive. And she also has tinnitus. A ringing sensation in the ear is called as tinnitus, and this is pulsatile in nature. On examination, you see there is a reddish mass behind the tympanic membrane and an audible brew is heard over the mastoid on auscultation. Her Rinne test is negative. So when Rinne is negative, you'll think of external or middle ear disease, because Rinne is negative in conductive hearing loss. So conductive hearing loss means conductive pathology. So what is the most likely diagnosis? CSOM, ASOM, mastoiditis, or glomus tumor? Yesterday again we have discussed some of the important signs of glomus tumor. Absolutely right. So gradually progressive conductive hearing loss, pulsatile tinnitus, Rinne is negative, reddish mass, which we call it as rising sun appearance. All of this are in favor of your answer, glomus tumor. Now, very importantly, you should remember is glomus tumor secretes catecholamines, which are your epinephrine, norepinephrine, dopamine. These are the catecholamines that they secrete. So you should look for symptoms of sympathetic excess like headache, sweating, palpitation, etc. And then there are some specific signs that you need to know. The clinical signs that we see in glomus is, the first one is called as rising sun appearance. Then you have a sign where you increase the pressure in the external auditory canal. The tumor vibrates vigorously and becomes pale, which is called as the Brown sign. The third sign which you see in a patient with glomus on clinical examination is compression of the carotid will make the tumor pale, which is called as your Aquino's sign. So these are all your clinical signs. Then what is your radiological sign? So radiologically, in a patient with glomus tumor, you're going to see two important signs. The first is on a CT scan, a contrast enhanced CT scan, which is the investigation of choice. You will see there is a sign which is called as the Phelps sign. And additionally, on an MRI, you see an appearance which is called as salt and pepper appearance. So these are the different signs that you see clinically and radiologically in a patient with glomus. The treatment of glomus is embolization followed by surgical excision. So please remember the pulsatile feature is that of the tinnitus. If they ask you pulsatile tinnitus, glomus. But if they're asking you pulsatile otorrhea, then your answer will change. Pulsatile otorrhea is a feature that you see in patients with ASOM or mastoiditis. So this is a feature of ASOM or mastoiditis where you see pulsatile otorrhea. So do look into the question, is it pulsatile otorrhea or pulsatile tinnitus? Great. Yes, Harjit Sharma, glomus tumor, glomus jugular are the same. So glomus has two types in the ear. One is called as glomus tympanicum. The second one is called as glomus jugular. So if the tumor is coming from the tympanic plexus, which is there on the promontory, we call it as glomus tympanicum. But if it is coming from the jugular, then we call it as glomus jugular. Okay, fine. Let's go to the next question. A school-going child presents with a history of recurrent upper respiratory tract infections, mouth breathing, and impaired hearing. On examination, high arched palate is noted. What is the management of this condition? Tonsillectomy, adenoidectomy with Grome insertion, myringotomy with Grome insertion. Again, a very typical question. So there is a school-going child presenting to you with upper respiratory tract infection, mouth breathing, impaired hearing. There is high arched palate. So what are you thinking of? What are you thinking of? So here we are thinking of adenoid hypertrophy causing what? Serous otitis media. How do I know serous otitis media? Because the child is having impaired hearing, the child is not having pain, the child is not having fever. So if the child is not having pain, no fever, and there is an adenoid hypertrophy, you are going to first treat the cause, which is doing an adenoidectomy, and along with that, to treat the serous otitis media, you're going to do a Grome insertion. So you will do a myringotomy. Through that myringotomy, you will put a ventilating tube which is called as Grome. So the answer is C, adenoidectomy and Grome insertion, which I see all of you have answered it rightly. Very good, all of you. So that was your December 2021. Now let's go to June 2021. Then we'll do 22 and Jan 23 questions as well. Okay. A 60-year-old diabetic presented to you with severe ear pain. So diabetes, pain in the ear, and there is otorrhea, not responding to antibiotics. Examination is showing to you granulation in the external auditory canal and facial nerve palsy is present. What do you need? All the ingredients for a diagnosis is present here to make you a good mix of a good dish. What are we talking about? So diabetes, pain, discharge, not responding to antibiotics, granulation tissue in the external auditory canal plus facial palsy makes it very easy for you to diagnose a simple disease, which is your malignant otitis externa. Absolutely right, Tina Redu, very good. The answer is malignant otitis externa. Harjeet, Alam, Sheikh, Mishra, Kumari, Shubjyoti, everybody, you're right. The answer is malignant otitis externa. So this is a pseudomonal infection that you see in elderly and diabetes. Now this pseudomonal infection is aggressive infection. It is not a infection that will respond very quickly. So it's a very aggressive infection and you have to treat it very aggressively by giving anti-pseudomonal antibiotics. Piperacillin, tazobactam are usually the drug of choice. Okay. Otomycosis typically presents to you with a wet newspaper like appearance. Serous otitis media presents to you with a dull, lusterless, air fluid level, air bubbles, tympanic membrane. Okay, so I think the answer is very clear. Malignant otitis externa. What is this view called in which the maxillary sinus is seen as the best? So what is this view called, which is your occipitomental view? The radiations are giving from the occiput towards the mentum, which we call it as the occipitomental view. So occipitomental view is used for visualizing the maxillary sinus. What is the other name of this occipitomental view? Yes, very good. The answer is Waters view. So remember, M for M, mental view is for your maxillary sinus. Reverse M, you get W, which is your Waters view. So Waters view is for your maxillary sinus. Downey's view, Law's view, Stenver's view are not for the paranasal sinuses. They are for the ear, to assess the middle ear and the mastoid. Okay. Let's go to the next question. Harjit Sharma, open mouth. Now, if the mouth is open like this, then we call it as Pierre's view. Typically, we are not talking about Pierre's view because they have asked you this is for maxillary sinus. So that is why the name will be Waters view. In Waters view, the mouth is closed. But in Pierre's view, it's the same occipitomental view, but the mouth is open. That's the difference. Okay, an elderly diabetic female who was treated with steroids and remdesivir for COVID now presented with a foul smelling discharge from the nose. On examination, black necrotic mass filling the nasal cavity and eroding the septum and hard palate. What is the most probable diagnosis? Aspergillosis, mucormycosis, foreign body, or is it rhinosporidiosis? Again, I think this is a very simple, easy question. What do you think is the answer, guys? So I'm sure all of you know the answer. Elderly, diabetic, post-COVID, post-steroid, post-remdesivir is having now blackish foul-smelling discharge from the nose. We are very sure and confident that the diagnosis is nothing but mucormycosis. So diabetes plus immunosuppression plus aggressive infection plus black foul-smelling crust and discharge from the nose, necrotic mass in the nose and the septum and hard palate, all of this are enough for us to diagnose it is mucormycosis. The drug of choice for mucormycosis is amphotericin B. Typically, amphotericin B is extremely nephrotoxic. And hence, what do? We don't give the lyophilized form, we give liposomal form of amphotericin B. So the drug of choice is liposomal form of amphotericin B plus radical debridement of the tissue. So you have to debride the tissue to its maximum. So radical debridement plus amphotericin B is the drug of choice. Okay. Which of the following conditions does not form a grayish white membrane over the tonsil? Streptococcal tonsillitis, diphtheria, Ludwig's angina, infectious mononucleosis. Now, basically, you should know that all of them can form a membrane on the tonsil except. So the question is does not. Yes. So here what we have the options, there are three options where you will see that they can form a membrane on the tonsil. The streptococcal tonsillitis, of course, it is not grayish white, pearly white, but sometimes you can have even grayish white also. Diphtheria also can present to you, I mean, it typically presents to you with a grayish white membrane. Infectious mononucleosis also is a differential diagnosis for white membrane on the tonsil. Ludwig's angina is a condition which is cellulitis of the floor of the mouth. It doesn't have anything to do with the tonsillar tissue. It will present to you with hard woody swelling in the submandibular region. So it presents to you with a woody hard swelling in the submandibular region. Okay, but streptococcal tonsillitis, diphtheria, infectious mononucleosis, although not very typically grayish white, but they are differential diagnosis for a membrane on the tonsil. But Ludwig's is not a differential diagnosis for a membrane on the tonsil. Okay. Yes, Dhruv, Vincent's angina can cause a membrane on the tonsil, but usually it is blackish, grayish black. In which of the following conditions is the B type of tympanogram seen? Ossicular dislocation, otosclerosis, serous otitis media, normal ear. So typically whenever we talk of tympanograms, I always give a quick shortcut for all of the learners that if you take this as the x-axis, mark 0 in the midline, and take this as the y-axis and mark the midline of the y-axis as well. Now, if you have a graph where you have an ascending curve, a peak and a descending curve. Now see, is the peak at 0 and is it occupying half of the length on the y-axis? This type of a graph, we would call it as a type of graph. Now, if you have a graph where it is occupying the peak at 0, but it is a smaller graph, not occupying half of the length on the y-axis, we will call it as AS. If you have a graph where the two curves are discontinuous with each other, you will call it as AD. If you get a single flat line, you will call it as B. And if you get a graph where the peak is occupying half of the length on the y-axis, but it is at negative pressure, minus 10, minus 20, sorry, minus 100, minus 200, then you call this as C type of a graph. So A is a normal tympanogram. AS is seen in otosclerosis. AD is seen in ossicular discontinuity. B type of graph is seen whenever you have fluid in the middle ear, and C type of graph whenever you have a eustachian tubal obstruction causing a negative pressure. So B type of graph is seen in serous otitis media. So the answer is serous otitis media. So serous otitis media is a condition where you have fluid, ossicular dislocation AD, otosclerosis AS. So I hope this was very easy for all of you. Okay, now let's go to the next question. The image given below is from a chronic smoker's oral examination. Identify the lesion given. Is it erythroplakia, leukoplakia, Fordyce granules, or Koplik spot? So you see there is a white patch on the tongue, and this white patch that is there on the tongue is seen in a chronic smoker's oral examination. So where or identify the lesion given. Is it erythroplakia, leukoplakia, Fordyce granules, or Koplik spot? A very easy question. Good, all of you. The image that is shown to you is very, very specific, and the answer that you see is that of leukoplakia. Erythroplakia will present to you as a reddish patch, not as a whitish patch, reddish patch. Both of them are pre-malignant lesions, whether it is leukoplakia or whether it is erythroplakia. Both of them are pre-malignant conditions. Okay, now if you see Fordyce spots, these are normal sebaceous glands which become apparent, more visible in some individuals. So if you see a picture like this, these are normal sebaceous glands which are seen very apparent. These are called as Fordyce spots. And you see this reddish ulcers with a whitish base, this is called as Koplik spot, and this Koplik spots is seen in patients of measles. So this is how different oral cavity lesions would look like in patients with measles, in Fordyce, and in erythroplakia and in leukoplakia. Okay, let's go to the next question. Identify the sinus marked in the image. Is this your frontal sinus, piriform sinus, ethmoid sinus, or the maxillary sinus? Again, a very, very easy question. So you have some sinuses marked. So they're asking you this sinus, but I'm asking you the other sinus also. The first sinus that you see here in the cheekbone, in the maxillary bone, is that of your maxillary sinus. So the question that they have asked you is for that of the maxillary sinus. Now, if you see here, the second marking that I have done is in the forehead. So this is your frontal sinus. Medial to the eye, here you will have your ethmoidal sinus. And through the mouth, what you see here, this one is your sphenoid sinus. So I hope everyone knows the locations of the sinuses. So the view that you see here is the Pieris view, but the image is showing you the marked structure of that of the maxillary sinus. Great. Now let's go to the next question. Which of the following is the main arterial supply of the palatine tonsil? Tonsillar branch of the facial artery, descending palatine branch of the maxillary artery, buccal branch of maxillary artery, ascending palatine branch of the facial artery. So what is that main blood supply of the tonsil? So there is a quick mnemonic to remember the blood supply of the tonsil, which you can remember with TDAD. Okay, so T stands for tonsillar artery, which is a branch of your facial artery. And then you have another D. D is standing for descending palatine. A is for ascending palatine. Another A stands for ascending pharyngeal. And the last D is for dorsal lingual branches of the lingual artery. So all of this are branches of your external carotid artery, and the main blood supply to the tonsil is from the tonsillar artery, which is the branch of your facial artery. So good, everyone's answered this right. So Dhruv, Maisam, Homo sapiens, Nimisha, Sanjay, Shrishti, very, very good. Okay. A child with bilateral sensorineural hearing loss was given hearing aids which had not been beneficial. Which of the following is the next treatment option for this child? Bone anchored hearing aid, tympanoplasty, normal hearing aid, cochlear implant. So basically, they're telling to you that there is a child who has bilateral sensory neural hearing loss and there is no benefit with hearing aid. So ear amplification devices which you have given in the form of hearing aid is not useful. So now you have to bypass the external ear and the middle ear and give an amplification device directly to the cochlea so that the sound impulses can go now from the cochlear nerve to the brain, because both the sides the patient is having a problem which is not getting resolved with a hearing aid. So what will you do? Will you give a Baha which will send the sound impulses to the cochlea? No. Will you do tympanoplasty, which is reconstruction of the middle ear? No. Normal hearing aid has not responded. So an indication for a child who presents to you with bilateral hearing loss that is not responding to the hearing aid, your answer should be cochlear implant. So cochlear implant surgery is performed for bilateral profound sensory neural hearing loss. So if there is a patient who has bilateral profound SNHL not responding to hearing aids, that is sufficient for your answer of cochlear implant. But if the question would have been unilateral profound SNHL, then you can give Baha. So if there was a unilateral profound SNHL, if there was an external ear or a middle ear disease, then you can give Baha. If the question would be bilateral moderate or severe hearing loss, then your answer will be hearing aid. But if your question is, if there is a cochlear nerve abnormality, the nerve is not functioning, this is not functioning, then what will you give? Then you will rehabilitate with auditory brainstem implant, where you put an implant in the brainstem. So these are all your mode of rehabilitation. So if the question is asked to you, based upon that your answer will change. If they ask you unilateral profound SNHL, then go for Baha. Any external auditory canal atresia, middle ear disease, go for Baha. Bilateral profound SNHL, cochlear implant. Cochlear nerve is abnormal, where the cochlear nerve is not functioning, you have to put an implant in the brainstem, so you will do an auditory brainstem implant. And if they ask you a question with moderate or severe hearing loss, then your answer will be hearing aid. So I hope everyone's understood the modes of rehabilitation for hearing loss. Okay. Which of the following laryngeal cartilages is least likely to be calcified? Again, a simple, easy question. So, what laryngeal cartilage is least likely to get calcified? Thyroid, cricoid, arytenoid, or epiglottis? Yes, I'm waiting for your answers. So out of this, there are three cartilages which are hyaline and one cartilage which is epiglottis. So basically, when we classify laryngeal cartilages, we have classification as paired cartilages and unpaired cartilages. Yes, so which are your hyaline cartilages, which are your elastic cartilages? So hyaline cartilages is your thyroid, it is your cricoid, and you have got the arytenoid. In your elastic cartilage, you have got the epiglottis, you have the corniculate, and you have the cuneiform. So elastic cartilages are these three. So they will usually not calcify, whereas all the hyaline cartilages are calcifying cartilages. So hyaline cartilages will calcify, elastic cartilages won't. So epiglottis will not calcify. So the answer is epiglottis. Okay, now next question. Which of the following nerves is responsible for ear pain after a tonsillectomy surgery? Glossopharyngeal nerve, facial nerve, trigeminal nerve, vagus nerve. Yes, very, very good. All of you are, I'm seeing, are answering it absolutely right. So, following tonsillectomy. So, basically, we should know tonsil lies where. So, tonsil lies in your oropharynx. The entire oropharynx is supplied by which nerve? The entire oropharynx is supplied by your glossopharyngeal nerve. So oropharyngeal, if there is a tonsillectomy or there is a tonsillitis or there is a foreign body in the tonsil, there will be stimulation of glossopharyngeal nerve. Now, this glossopharyngeal nerve gives a branch in the middle ear, which is called as the tympanic branch of the glossopharyngeal nerve. And this tympanic branch of the glossopharyngeal nerve is called as Jacobson's nerve. So it's very simple. Following any oropharyngeal lesion, whether it is tonsil, whether it is base of tongue, whether it is lingual tonsil, the pain will be referred via which nerve? Via the glossopharyngeal nerve. If there is any laryngeal pathology or there is a hypopharyngeal pathology, the pain will be referred to the ear via which nerve? Via the vagus nerve. If there is any oral cavity, any TMJ pathology, then the pain is referred via which nerve? Via the trigeminal nerve. So these are all the nerves that can cause referdotalgia. Of course, C2, C3 also can cause referdotalgia, but these are the main ones that you should know. So the answer is glossopharyngeal nerve. Okay, so that completes your entire 21 session. Yesterday we did 20 and 19 questions. So 3 years questions are done. We'll do 22 now and Jan 23 questions. So your last 5-year questions will become complete. Okay. Okay. What is the view called in which the frontal sinus is seen the best? Caldwell's view, Townes' view, auriculotemporal view, Stenver's view. So basically, Indian in parotid lesions, when we are trying to do a parotidectomy, there are two nerves at risk, the auriculotemporal nerve and the greater auricular nerve. But typically, since the incision goes into the lower part of the pinna near the angle of the jaw, the nerve that is at highest risk is your greater auricular nerve. Okay. Now, what is this view called in which you see the frontal sinus at its best? So the frontal sinus is seen best in Caldwell's view, Townes' view, Law's view, or Stenver's view. So in which view will you see the frontal sinus? So we know Waters' view is for maxillary sinus. Caldwell's view is for which sinus? Frontal sinus. So Caldwell's view is for your frontal sinus. Okay, and then we have Pierre's view. This is for your sphenoid sinus. So now we hardly do take any x-rays, whether it is for sinuses or whether it is for the ear. We do not prefer to take any x-rays. We prefer to do a CT scan, which gives us a better idea or better understanding. Okay. Now this again a question, a typical repeat which came constantly in 2 back-to-back years, and you could expect this topic again. So again the same formula: diabetes, elderly, black color discharge from the nose, black necrotic mass in the nasal cavity, septum eroded, hard palate eroded. Is it aspergillosis, mucormycosis, foreign body, or the other option I don't know, which was not given by the students? So what do you think is the answer? Yes. So I think this is very, very clear, very easy, very simple. So elderly, diabetic, black, foul-smelling crust, erosion of a disease, you should think about mucormycosis. So basically, if we talk of invasive fungal infections, so we can classify fungal infections as non-invasive and invasive. So when we're talking about invasive fungal infection, there are two types. One is aspergillosis and mucormycosis. Aspergillosis will typically present to you with greenish crust, not blackish crust. Whereas mucormycosis is a rapidly progressive fatal infection presenting to you with a blackish mass, because this mucor is supposed to be angio-invasive. Since it is angio-invasive, it is known to invade the blood vessels and cause this blackish discoloration and crust. Okay, and if I talk of non-invasive fungal sinusitis, so I've told you about invasive. How do we classify? If we have to talk about non-invasive fungal sinusitis, non-invasive fungal sinusitis can be classified into two types. It can be fungal ball, or either it can be allergic fungal rhinosinusitis, AFRS. So here we know blackish discharge, black necrotic mass, erosive disease, diabetes. The answer is going to be mucormycosis. We've already discussed the treatment, so let's go to the next question. Again, a typical repeat. So if I have to tell you, in ENT, most questions are repeat, and if you know the PYQs, for sure ENT is just going to be a cakewalk in your exam. Trust me on this. Out of the 10 questions, at least 7 to 8 you can answer. You will be confident. So just do your PYQs before your exam. A 60-year-old diabetic presented with severe ear pain and otorrhea, not responding to antibiotics. On examination, granulation tissue, facial nerve palsy. What is the likely diagnosis? Very easy question. I think we have already solved this. There is no doubt when we are talking of diabetes, pain, not responding to antibiotics, granulation tissue present, and facial nerve palsy, the diagnosis goes straight to the malignant otitis externa. Okay, the next question. 35-year-old male presented to the ENT clinic with complaints of episodic vertigo, sense of pressure and fullness, which we call it as oral fullness, and decreased hearing and a low tone roaring tinnitus. So vertigo, okay, well, I don't know sensory neural or not, but definitely hearing loss they have mentioned, and they have mentioned to you tinnitus. So vertigo, hearing loss, tinnitus. What is the probable clinical diagnosis? So what do you think is the answer? Is it Meniere's, BPPV, labyrinthitis, or syncopal reaction? So this is also very easy. Whenever you have a patient with hearing loss, it cannot be BPPV, because BPPV presents to you with only vertigo. There is no hearing loss and there is no tinnitus. And the vertigo in BPPV is just lasting for a few seconds to a few minutes. Okay, so that cannot be the cause. Now, labyrinthitis can present to you with vertigo, hearing loss, and tinnitus, but it doesn't have episodic vertigo. It has a constant vertigo. It will have a single long episode of vertigo. So, if you have a patient who has a single long episode of vertigo lasting for days and months, you should think about labyrinthitis. Syncope, again, tinnitus will not occur. They might have just a vertigo or uneasy feeling, but no hearing loss and no tinnitus. The answer is Meniere's disease, where they have got episodic vertigo lasting for few minutes to few hours, associated with nausea, vomiting, vagal symptoms. There is a sensory neural hearing loss, and there is roaring type of tinnitus. So this is how you will classify the vertiginous disorder. So if you have vertigo for minutes to hours, your answer will be Meniere's disease. For few seconds to few minutes, your answer will be BPPV. Single long episode of vertigo for days to months, the answer will be labyrinthitis. Hearing loss is absent in BPPV but present in Meniere's and labyrinthitis. Yes, so I think this question is easily understood by everyone. Okay, let's go to the next question. Again, a very simple, easy repeat topic. A primipara is being evaluated for hearing impairment, which had worsened during her pregnancy. So, hearing loss, what is happening? It is getting worsened during pregnancy. Rinne's test is negative in both the ears. So, what is happening to Rinne? Right and left is being negative. Weber is going to which side? Weber is going to the Weber's test is lateralized to the right side. On otoscopy, tympanic membrane appear normal. So tympanic membrane normal. Audiometry is showing a dip at 2000 hertz. So what is your audiometry showing? Dip at 2000 hertz. What is the treatment of choice for the above condition? Is it sodium fluoride? Is it tympanoplasty? Is it stapedectomy? Or is it stepidotomy? So a primipara meaning following history of delivery or pregnancy. Following this, there is hearing loss that is getting aggravated. Rinne negative bilateral meaning conductive hearing loss. Our diagnosis falls in the category of otosclerosis because we see a notch at 2000 hertz which is called as Kerhart's notch, and Kerhart's notch is specific for otosclerosis. Now, how do you treat it? The initial treatment will be to give hearing aids. If there is an active lesion, you are going to give sodium fluoride, meaning right now there is active deposition happening. There is no role of tympanoplasty in otosclerosis. Stapedectomy and stepidotomy, both are the surgeries done, but the surgery of choice is stepidotomy with placement of prosthesis. You can do both, but this is the surgery of choice. So the correct answer is D, which is stepidotomy with placement of prosthesis. Okay. Okay, next question. In which of the following condition is a BAHA use? I have explained this to you. Sensory neural hearing loss, acoustic neuroma, congenital external auditory canal atresia, otitis media. So bone anchored hearing aid has got a specific indication. So Indian 4000 Hertz dip is seen in AC and BC curve in a patient with noise-induced hearing loss. So when there is a NIHL, noise-induced hearing loss will present to you with a dip in AC and BC. Okay, so in which of the following conditions is a BAHA used, bone anchored hearing aid used? So bone anchored hearing aid is used whenever you want to bypass the external ear and the middle ear and you want the sound impulses to go directly to the inner ear. So if I have a patient who has external auditory canal abnormality, pinna abnormality, middle ear abnormality, I can anchor a screw here. Over that, I'll put a receiver and the sounds will go directly through the bone to the inner ear, and from here they will be carried to the brain. So it is typically used for external ear or middle ear abnormalities. It is also used in unilateral SNHL. So whenever one cochlea is not functioning, the sound can go towards the opposite cochlea and from there to the brain. So it can be used only in unilateral SNHL. If bilateral SNHL, it cannot be used. So the correct answer will be 3. Correct everyone, which is your congenital external auditory canal atresia. Okay. A 60-year-old male presents to you with painless cervical lymphadenopathy. I have told you this topic is coming again and again. You see, yesterday we discussed, today we discussed, 20 it came, 21 it came, now in 22 also you are seeing this question. So painless cervical lymphadenopathy, and there is the right ear reveals conductive hearing loss with a dull tympanic membrane. There is decreased mobility of the soft palate, meaning palatal paralysis. What is your diagnosis? Nasopharyngeal carcinoma, adenoid cystic carcinoma, JNA, and Quincy. So first of all, JNA you will mark absent because it's not seen in 60 years, it's seen in juvenile age group. Quincy again presents to you not with a lymphadenopathy or hearing loss, presents to you with pain, difficulty in swallowing, which is nothing but your peritonsillar abscess. Now we know that painless cervical lymphadenopathy, unilateral SOM, 10th nerve palsy, all of them are features of nasopharyngeal carcinoma. So I don't think we have much for discussion over here. Let's go to the next question. Which of the following fungal infection is most commonly seen in the maxillary sinus? So tell me, which organism is most commonly responsible for fungal infections in the paranasal sinuses? Is it your blastomycosis, aspergillosis, candidiasis, or histoplasmosis? Yes, everyone, very good. The answer is aspergillosis. So when we come to fungal infections of the paranasal sinuses, the most common organism that is responsible for causing this fungal infection is your aspergillosis. So aspergillosis is the most common organism responsible for causing fungal infection. Okay, the next question. A 4-year-old boy presents to you with a low-grade fever. There is inspiratory stridor and there is a barking cough. The word barking cough is used. Straight something has to strike into your head. Examination reveals there is a hoarse voice and there is a moderately inflamed pharynx with slightly increased respiratory rate. The chest x-ray showed subglottic narrowing like that of a steeple. So you know two important words are given to you, barking cough, and they have given to you another very important word, which is your steeple sign. Which among the following is not indicated in the treatment? Nebulized racemic epinephrine, parenteral cefotaxime, helium oxygen mixture, intramuscular dexamethasone. So which one is not indicated in the treatment? So what are we talking about? Barking cough, steeple sign, there is narrowing of the subglottis, hoarseness of voice. We are talking about acute laryngo tracheobronchitis. So in ALTB, acute laryngotracheobronchitis, you will see this condition where the patient will have fever. Now, typically this is seen in younger age group between 3 months to 3 years of age. Already they will have small airways. Edema will cause further narrowing and respiratory distress. So, steroid and epinephrine form a very important part of the management. Now, although it is caused by viral infections, you need to give an antibiotic. You will have to give an antibiotic. Some of you marked two, but you will have to give antibiotic to just prevent super added bacterial infection. Once there is a super added bacterial infection, the condition will only worsen. So you will give bacterial, parenteral cefotaxime. Helium oxygen mixture is not necessary. If necessary, you can give 100% oxygen, but not helium oxygen mixture. This is not a part of the treatment in a patient with LTB. Okay. So I'm sure everyone got it now. Okay, let's go to the next question. This is again a same question which you have seen some time ago in the last exam. A 7-year-old child post tonsillectomy comes to you with snoring, palpitations, mouth breathing, and slight decrease in hearing. So all the symptoms that you need to know in a 7-year-old child. I mean, of course, you should understand what we're talking about. You notice there is a high arched palate. His school performance is deteriorating as well. His mother is worried. What is the next line of management? So, are we thinking of adenoid hypertrophy? This adenoid hypertrophy, is it causing compression of the eustachian tube resulting in serous otitis media? And if it is causing compression of the eustachian tube with serous otitis media, will it result in hearing loss? Yes. And now if you have to treat the hearing loss for because of SOM, you will do a myringotomy and Grome. But should you treat the underlying cause? Yes. So the correct answer will be adenoidectomy with Grome insertion. I'm sure everyone has answered this right. Okay, you see a child with delayed speech development as a part of the health visit at a local school. The otoscopic appearance of the ear is shown below. Hearing loss of 20 decibel is detected on the audiometric test. What is your diagnosis? So very easy, child, delayed speech, and otoscopic examination is showing you something. There is, okay, I'll give you a clue if you're not able to see the image very nicely. So you see there is an air level above and a fluid level below. So if you have an air fluid level, what should your diagnosis be? The answer is going to be absolutely right, serous otitis media. One quick indicator for all of you. So if you have a child and if this child has got pain, fever, hearing loss, your answer should turn to ASOM most commonly. But if this is a child who has only hearing loss, no pain, no fever, then your answer should turn to SOM. So I hope you're able to get the answer. The answer is going to be serous otitis media. Okay. Okay. A patient with a history of trauma presents to you with diplopia, epistaxis, and restricted eye movements. So you can see there is diplopia, epistaxis, and restricted eye movement. CT image is given below. You can see clearly something is happening over here. The floor of the orbit has got fractured and it has gone into the maxillary sinus. The contents of the maxillary sinus also have prolapsed. The content of the orbit has also prolapsed in the maxillary sinus. So what will your diagnosis be? Is this your Le Fort fracture? Is this your fracture of the maxilla? fracture of the zygoma, or is this your blowout fracture? Very easy question. I think everyone knows this, where you get a teardrop sign and you get, impingement of the inferior rectus muscle. Yes, what are we talking about? Yes, very, very good, all of you. Tanzeen, Amit, Naira, Shrishti, Ranu, Homo sapiens, Krishna Kumar, Mohammad Shafi, Mix Sub Jindagi, all of you. The answer is blowout fracture. Leaford fracture is nothing but fracture of the maxilla. Zygomatic fracture is also called as tripod fracture. So zygomatic fracture would be seen somewhere here. You would see 3 fractures, and Leaford fracture would be either Leaford 1 like this, floor of the nose and floor of the maxillary sinus, Leaford 2 going like a pyramid, and Leaford 3 which would be your craniofacial disjunction. So here we are very clear, this is a blowout fracture. A patient presented with surgical emphysema after an emergency tracheostomy. What is the most likely reason? High tracheostomy, tear in the posterior wall of the trachea, block in the tracheostomy, or a tight suture around the tracheostomy site. So they're telling to you there is a surgical emphysema following an emergency tracheostomy that you have done. What is the cause of this subcutaneous emphysema? So basically we know that the larynx continues inferiorly as trachea. So if I make an incision in the neck and I open the trachea through this incision, when I put a tube inside and when I have made an opening in the trachea, is there a possibility that the air can leak from the sides of the wound? Yes. And if I have sutured the skin very tightly around the stoma, what will happen? Can there be subcutaneous emphysema? Yes. So this occurs due to tight suturing around the tracheostomy wound, not letting the air to escape out. So always do not do a tight suturing, do a little loose suturing to allow the air to escape, just in case there is any leak around the tracheostoma. So most likely reason, block will not present to you with surgical emphysema but as respiratory distress and falling saturation. Injury to posterior tracheal wall will result in a tracheoesophageal fistula. High tracheostomy will always or possibly result in subglottic stenosis. Okay, great. That completes your 22 questions as well. Now we have the latest examination, which is your Jan 2023, and the background that I'm using is purposely black so that if you want to revisit this question, you have to go from this area so that you'll be able to get the latest questions of the Jan 23 session. Which of the following is true regarding the external nose? Bony third, bony 1/3, cartilaginous 2/3, bony 2/3, cartilaginous 1/3, bony half and cartilaginous half, bony 1/3 and cartilaginous 1/3. So if you take the external nose is made up of a bony pyramid and a cartilaginous pyramid. How much is your bony part? How much is your cartilaginous part? The bony part accounts to 1/3 and cartilaginous part accounts to 2/3. Okay, so the bony part is made up of how many paired bones? 2 paired bones. One, you have got the nasal bone and you have got the ascending process of maxilla. So this is made up of 2 paired bones. Which are those 2 paired bones? The nasal bone and ascending process of maxilla. Then you have got one unpaired bone which comes from above. This is your frontal bone. It's made up of one unpaired bone, and that one unpaired bone is your frontal bone. Then you have got cartilaginous part. The cartilaginous part is made up of upper lateral cartilage, lower lateral excuse me, sorry. It is made up of upper lateral cartilage, lower lateral cartilage, and sesamoid cartilage. So how many cartilages? 3 paired cartilages. Which are the three paired cartilages? Upper lateral cartilage, lower lateral cartilage, and sesamoid cartilage. And it is made up of one unpaired cartilage, and that one unpaired cartilage from below that comes to support the dorsum of the nose is your septum. So this is regarding the external nose anatomy. So it is made up of bony 1/3 and cartilaginous 2/3. Thank you, Nature with Medicos. Okay. The patient with Bell's palsy came to you with complaints of deviation of face. The deviation of face is seen on which side? Same side lower part, same side upper part, opposite side upper part, opposite side lower part. So whenever you have Bell's palsy, what are we thinking of? We are thinking of facial nerve palsy. So facial nerve innervates the facial muscles. Now we know that the forehead receives bilateral innervation. So whenever we talk of Bell's palsy, forehead is paired. So if the forehead is paired, can there be deviation on the forehead or the upper part of the face? No. So upper part you can easily rule out. Now same side lower part or opposite side lower part. So if I say there is Bell's palsy on the right side, the right sided facial muscles will become weak. And as a result, the opposite muscles are stronger. They will pull the face towards the opposite side. So the deviation is towards the opposite side lower part, not on the same side lower part. Okay. All of you got it? It's not on the same side. It's on the opposite side because the facial muscles are weak. They cannot contract. But the other side, the facial muscles are powerful. So they will get contracted towards the opposite side. Okay. Fine. Let's go to the next question. I see some of you are doing it wrongly. I hope this is answered by all of you. Teerth, Game Changer, Naira, Shahrukh. Okay, a 16-year-old male presented to you with recurrent profuse bleeding from the nose. What should be the treatment in this patient? So we have again a same question, 16-year male, recurrent profuse epistaxis. What is your diagnosis? So the diagnosis for this question is going to be juvenile nasopharyngeal angiofibroma. So what should be the treatment for this patient? Whenever we talk of juvenile nasopharyngeal angiofibroma, we know it is a very vascular lesion. So how do we reduce the vascularity of this tumor? To reduce the vascularity, we are going to embolize the tumor. So the treatment will be embolization. Embolization means blocking the feeding vessel. So embolization followed by surgical excision. So embolization followed by surgical excision will be the treatment of choice for juvenile nasopharyngeal angiofibroma. FNAC biopsy are contraindicated. You will not do this for a patient with JNA. Okay, radiotherapy is given only for recurrence or if it is inoperable lesion. So if there is a recurrence, you can't operate, then you're going to give radiation therapy. Okay. A 2-year-old child presented to the ER and the child was having difficulty in speaking and breathing. An X-ray was performed which is given below. Which among the following is the best treatment for the following condition? So you see there is a foreign body here in an X-ray antero-posterior view and you have a lateral view. So you are seeing a foreign body lying here. So what will you do in the treatment of, this patient's foreign body? Will you do a bronchoscopy, tracheostomy, esophagoscopy, or a Heimlich's maneuver? So you see this black shadow that I'm tracing is that of the airway. Behind that, what you see, this is your soft tissue shadow, that is your digestive tract. So where is your foreign body? Is it in your airway or is it in your digestive tract? Yes, so if you see, it is not in this black air column, it is in the gray soft tissue column. So since it is in your digestive tract, especially in the upper part at the upper esophageal sphincter or the cricopharyngeal sphincter, to get that foreign body out, you will have to do a esophagoscopy. So the best treatment will be to do a esophagoscopy and remove the foreign body. Okay, which sensory nerve supplies the larynx above the vocal cord? internal laryngeal nerve, external laryngeal nerve, recurrent laryngeal nerve, superior laryngeal nerve. So sensory supply to the larynx above the level of vocal cords. So whenever we take the nerve supply of the larynx, we divide, I usually tell my students to take larynx like a box and take this as the vocal cords. The upper half of the larynx receives its sensory supply from internal laryngeal nerve, whereas lower half receives its sensory supply from the recurrent laryngeal nerve. The sensory supply above the level of vocal cord is via the internal laryngeal nerve. External laryngeal nerve doesn't have sensory fibers, it has motor fibers. So motor fibers, for which muscle? It is for your cricothyroid muscle. A recurrent laryngeal nerve is sensory below the level of vocal cords, and it has got motor fibers to all the muscles of the larynx. So motor to all muscles of larynx except cricothyroid. So it supplies all the muscles of the larynx except the cricothyroid muscle. And superior laryngeal nerve branches only are your internal and external laryngeal nerve. Correct? So I hope everyone got the answer to this question. Okay, what is the function of utricle and saccule in the inner ear? Linear motion and angular motion. Linear motion helps in hearing of low frequency sound, helps in hearing high frequency sound. What is the function of utricle and saccule? So basically, whenever we talk of utricle and saccule, the main function of both of them is balance, and they also are responsible for hearing. But when we come to frequency specific hearing, they have got no role in frequency specific hearing because frequencies are localized in cochlea. So where are the frequencies localized? The frequencies are localized in cochlea. Lower frequencies are heard at the apical turn. So lower frequencies are at apical turn. Higher frequencies are heard at the basal turn. So higher frequencies are held at basal turn. So we are cutting off the frequency C and D option because that is not the function of utricle and saccule. Now coming to angular motion. Angular motion is a specific function of your semicircular canals which contain the crista. It's not a function of utricle and saccule. But for all the functions of balance like linear motion, linear acceleration, deceleration, position of head against gravity, static equilibrium, for all the other functions of balance, it is going to be your utricle and saccule. So the correct answer is B, which is your linear motion. Okay, identify what is this sinus, which is the most biggest sinus and the prominent sinus. Is this sphenoid, ethmoid, maxillary, or frontal? If you see, these are very simple questions, but they're often repeated. 22 it was there, 21 it was there. So you can expect such easy questions. You just have to have your frame of mind in the exam. Don't get tense, don't get stressed. You will be able to answer it right only if you have the right frame of mind. Yes, so very good. The most prominent sinus that you see here is that of the maxillary sinus, which is present below the orbit, lateral to the lateral wall of nose in your cheekbone. This is your maxillary sinus. The cells which are localized near the medial wall of the orbit, these are your ethmoid sinuses. And if we go cuts anteriorly, then we can see the frontal sinus. So the answer is maxillary sinus. Okay, a 35-year-old female takes a tablet of aspirin for headache. So she took what? Aspirin. Later she presented with wheezing and breathlessness. The symptoms are most likely due to which of the following? IgE release, nasal polyp, drug interaction, extrinsic asthma. So I answer very quickly. So IgE release happens whenever there is an allergic reaction. So is the patient having allergic reaction causing IgE release and causing the symptoms of breathlessness and wheeze? The symptoms that have been shown to you over here, like aspirin presenting to you with breathlessness and wheeze with nasal polyp, is a part of a triad which we call it as Samter's triad. Okay, so in Samter's triad, the patient is sensitive to aspirin. The patient is having nasal polyp. And this is not an extrinsic asthma because of some extrinsic provoking factor. This is an intrinsic asthma. So aspirin sensitivity, nasal polyps, and asthma, we call this triad as Samter's triad. So the examiner was trying to find out if you knew Samter's triad or not. So the correct answer is going to be nasal polyp. Okay, a patient whose teacher by profession complains to you, presented to the clinic with complaints of hoarseness of voice. Now, if you know teacher, singer, hoarseness of voice, there has to be something that has to come to you very spontaneously. Teacher's nodule, singer's nodule, hawker's nodule, what do you call it as? Yes, the correct answer is vocal nodule. Vocal nodule and vocal polyp. You need to know quick differences. So vocal nodule usually happens due to gradual voice abuse, whereas vocal polyp happens due to sudden voice abuse. Nodules are usually bilateral, whereas polyps are usually unilateral. Nodules are usually sessile, whereas polyps are pedunculated. Both of them occur at the same lesion, anterior one third and middle one third of the vocal cord. This is also at the same line. Vocal nodule will decrease with voice rest, and then if it doesn't decrease, then you will do a microlaryngeal surgery. But for a vocal polyp, you will have to do a microlaryngeal surgery. Both of them will have hoarseness of voice, but typically there is a voice that you see in vocal polyp which is called as diplophonia or double voice. So diplophonia is a feature of vocal polyp. Okay, so I think all of you understood the important features of vocal polyp, vocal nodule. Rinke's edema is if there is edematous accumulation in the anterior two-thirds of the vocal cord. There is fluid-like accumulation that happens, or edematous tissue that accumulates in the anterior two-thirds of the vocal cord. In the Rinke's space, which is your subepithelial space, we call it as Rinke's edema. Okay, the next question, which is again a repeat. 25-year-old female coming to you with decreased hearing and pulsatile tinnitus. If you hear the word pulsatile tinnitus, something has to strike to you. Examination showed a red and bulging tympanic membrane. What could be the diagnosis? Glomus tumor, serous otitis media, acute otitis media, or chronic otitis media? A very easy question which we have solved twice before, yesterday and today. A repeat question where you're seeing conductive hearing loss, where you're seeing pulsatile tinnitus, where you're seeing red and bulging tympanic membrane. Answer should be your glomus tumor. There is no doubt, but your answer is glomus tumor. Very good. Which type of tracheostomy tube is used in an ICU patient? Metallic tube, cuffed tube, uncuffed tube, fenestrated cuffless tube. So basically, when we are talking of an ICU patient, we mean that the patient requires ventilatory support or may require ventilatory support. Now, when I am putting a tube in the trachea of a patient who might require a ventilatory support, what all considerations should I take? Now, when I insert the tube, I don't want air to leak. So when I put a tube inside, I don't want air to leak around the tube. So I want a cuffed tube so that the air that I give from the tube will go down into the trachea and the airways without any air leak, allowing me to give a maximum tidal volume. So will you use an uncuffed tube or will you use a cuffed tube? You will definitely want a cuffed tube. So uncuffed tube is not a question. What is a fenestrated tube? Now we have tubes which have got holes. There is a hole so that whenever the patient wants to speak, he can close the tube temporarily. The air will get redirected to this fenestration and hit the vocal cords to produce voice. So fenestrated tubes are used whenever the patient wants to speak for voice production. But in an ICU patient, if I keep a fenestrated tube, is there a risk of aspiration? Yes. So can I put a fenestrated tube in an ICU patient? No. Metallic tube again in an ICU patient is difficult because your vein circuit usually cannot fit on a metallic tube. So the answer that you will use will be a cuffed tracheostomy tube. So I think everyone's answered the same thing. So very, very good. Okay, a person with Rinke's edema will have which of the following symptoms? Dysphagia, dysphagia for solids more than liquids, dysphagia for liquids more than solids, diplophonia, dysphonia. So Paras Patel, whenever we use a metallic tube, we use it for those patients who are on permanent laryngectomy, right? So they are on permanent, like they have done a total laryngectomy and there is a permanent tracheostomy, and now the patient has to use that tube constantly for his life. So if I give him a Portex tube, a Silastic tube, it is very difficult for them to maintain it. Plus it becomes expensive for lifetime. Metallic tube comes in 70-80 rupees, whereas this Portex tube comes for 800-900 rupees and a Silastic comes for 8,000-9,000 rupees. So when we talk of cost effectiveness for a patient who has to use a tube lifetime, metallic tube would be more preferable. Second thing, maintenance. Now if a patient has to use a tube lifetime, the maintenance has to be easy. So to sterilize a metallic tube, to wash a metallic tube is much easier than that of Portex and Silastic, making metallic tube comfortable for those patients who are on long-term tracheostomy or a permanent tracheostomy. I hope you got your answer, Paras. Yes. So in Rinke's edema, of course, this is a edema of the subepithelial space or the Rinke space. So when there is an edema of the Rinke space or subepithelial space, they will have diplophonia or dysphonia. One of the two should be the right answers. Books mention both, but if you have to choose one, the answer that you could choose better would be dysphonia over diplophonia. Okay. Fine. Lacrimal sac is present in which wall of the orbit? Now, if we take the eye, where do you see the lacrimal sac in relation to which wall of the orbit? Okay, so when we see the eye, there is an upper punctum, a lower punctum, giving rise to upper canaliculus, a lower canaliculus. Both of them will join to form a common canaliculus, which continues to form the nasolacrimal duct. And this nasolacrimal duct opens into the inferior meatus of the nose. So where does the NLD open? The nasolacrimal duct opens in the inferior meatus of the nose. Okay, so where is this lacrimal sac present? In which wall? It is present in the medial wall of the orbit. Okay, lacrimal sac opens into nasolacrimal duct. So I'm sorry, the upper canaliculus and the lower canaliculus opens into the sac, and this sac opens into nasolacrimal duct. So sac is present in the medial wall, whereas the lacrimal gland is present in the lateral wall. So lacrimal gland is in the lateral wall, lacrimal sac is present in the medial wall. Very, very good. A patient with Ramsay-Hunt syndrome, which ganglion is affected? Geniculate ganglion, otic ganglion, trigeminal ganglion, basal ganglion. Yes, so in patient with Ramsay-Hunt syndrome, which is called as herpes zoster oticus. So this condition, you have got the herpes zoster virus remains latent in which ganglion? So the herpes zoster virus remains latent in the geniculate ganglion. Now what is geniculate ganglion? Now the facial nerve comes from the inner ear to the medial wall of the middle ear. So when it is coming from the labyrinthine portion to the middle ear portion, it makes a turn. This first turn is called as first genu or geniculate ganglion. And initially when there is in childhood, there is some herpes zoster infection, the herpes zoster remains latent in this geniculate ganglion, and reactivation of this virus results in pain in the area, pain and vesicles in the area of distribution of facial nerve, along with facial nerve palsy, and there can be also eighth nerve involvement, eighth nerve palsy resulting in sensory neural hearing loss. So this is what that you see in herpes zoster oticus, Ramsay-Hunt syndrome, also called as Justine-Bieber syndrome. Okay, in view of mucormycosis, which of the following option has the least possible causes? Uncontrolled diabetes without ketoacidosis, broad spectrum antibiotics, neutropenia, prolonged use of antibiotics. So, which one do you think is going to be the least possible cause for a patient who has mucor? So, mucor occurs whenever there is an immunosuppression. So immunosuppression definitely occurs in diabetes and steroids. But does antibiotic cause immunosuppression? No. But neutropenia, is it going to promote infections or allow early infections? Yes. So all the three are risk factor, but antibiotics is the least possible cause. So the answer is going to be broad spectrum antibiotics. Very, very good. Now the next question. A patient presents with complaints of A patient complains with unilateral obstruction of the nose associated with watery nasal discharge and nasal bleeding. A diagnosis of inverted papilloma is made. Which is true regarding the following condition? Is it malignant, benign and non-invasive, benign and invasive, none of the above? Again, a very easy question. Inverted papilloma is a most common benign tumor of the nasal cavity. Even though it is benign tumor, it is locally invasive tumor. It is called by different name. It is called as Ringer's tumor. It is also called as Schneiderian papilloma. It is called as transitional cell papilloma. All of these are the names given for inverted papilloma. So it is benign and locally invasive. So the correct answer is C. It is benign and locally invasive. On histopathology, the papilla grow towards the stroma and not towards the surface. So this lesion is called as inverted papilloma. Okay. So that completes your questions, and I hope you got a quick insight of all the 5 years 23, 22, 21, and 90, 20 and 19. Yesterday we did 20 and 19. Today we did 21, 22, 23. And I'm hoping that all of you learned all the MCQs in a quick format. Although I would want to be more elaborate, but already this itself was taking so much time. So I tried to keep it concise, but yet give you all the high yield points during the sessions itself. If there is any doubt, please do not hesitate to reach out to me. I will be more than happy to help you. Please do like, share, and subscribe to the channel to get regular updates of all the shorts, the small information that we give to you in different ways. This is only going to help you recollect and to use your time effectively with studies to just, recollect important information on the go. Okay. So I hope to see you all again. And if there's anything that I can help you with, please do not hesitate. We are there for you. Take care and bye-bye.